Everybody knows. I thought we had a
Good
good
evening, good evening, good evening,
discussion.
and welcome to Couch Conversations with the Doctors, where health is wealth. On tonight, what night is it tonight? It is Monday night, and it is time for Couch Conversations with the Doctors. Well, Dr. Miller, why don't you do the roundtable introductions and take us away?
Oh, good evening, everybody. My name is Dr. James Miller. I am a retired internist. I retired in 2019. Practiced about 40 years in Chicago and in a couple of the near surrounding suburban areas. Since I've retired, I am still interested in healing the community. So, we're joining tonight, and hopefully, we can have some spirited conversation regarding some things that we can do to help to heal our community. So, I want to start out and go around and introduce everybody to, and so that you can get to know those that are participating. We'll start out with Dr. Graham. Dr. Graham, introduce yourself, please.
Thank you, Jim. My name is Dr. Graham, and like Dr. Miller, I retired in 2019. I worked in the Western suburbs as a specialist for 30 years. After retirement, I joined the congressman in his office, and it was an eye-opening and tremendously educational experience. I've now become interested in public health. It's a real honor to be here with my colleagues, and I'm trying to answer your questions as best I can.
Good. Thank you so much. Next, Dr. Terry Mason. Terry, could you introduce yourself?
Thank you, Dr. Miller. Grateful to. First of all, let me thank the Congressman and Nikki for this format. My name is Dr. Terry Mason. I am a happily retired urologist, and I worked in the city pretty much all the life that I've known about and practiced urology in the city, and also was commissioner of the Department of Health for the City of Chicago and chief operating officer for the Cook County Health and Hospital System. So I've had a wide variety of experiences, and I look forward to being able to share those where appropriate here tonight.
Okay, sounds excellent. Uh, Dr. Meyer, Dr. 100, introduce yourself, please.
Good evening. Thank you to Nikki and the Congressman. Very excited to be here. I'm Dr. Maya 100, always keeping it 100. Excited to learn and grow with our community. So let's go.
All right, all right. So, Congressman Davis, everybody has introduced themselves. Can you go ahead and tell the people about why we're here?
Well, I've been fortunate to have done a bunch of stuff related to health. I actually, and I don't think I've ever even mentioned this, I actually did a fellowship with the University of Illinois. We had a wonderful time. And so I often not forget that I did it, but I did it. I also did a stint with the Health Education and Welfare Department as a fellow when it was HEW before it became HRSA. I also was appointed to a commission by President Jimmy Carter and ran around with the secretary at that time, Joe Califano of HEW. And we used to eat in his lunchroom because he was, an appointee. But he said he had to bring his own chef. So whenever we ate in his lunchroom, we had to pay for it because he had to pay for his chef to be there. So I had a fair amount of experience doing things with the federal government. I was an HMO consultant, and I helped start two HMOs around the country. I worked with the Detroit Medical Foundation, which is the Black Doctors Association in Detroit, Michigan, same as the Cook County Physicians Association. And so we developed with them as their HMO consultant um, an insurance company, Omni Healthcare.
Mm.
And so I had a wonderful time working with them. And the lady who used to work with me, Mo Henry, her daughter called me today and we had a great laugh because I mentioned the fact that a lot of times when we used to meet, people would identify their degrees and they would identify the fellowships and all those things. I'm John Smith and, MSW, AHC or whatever. So Mo Henry identified herself and she said, I'm Mary Alice Mo Henry, CSTA. And somebody said, Miss Henry, could you tell us? I never heard of that designation before. She said, well, it just simply means that I have common sense, talent, and ambition. So everybody had a big laugh. Mo Henry lived to be almost 100 years old, and she did a whole bunch of things after she was 70. She got a college degree after she was 70 years old. She learned to drive a car after she was 70 years old, got a driver's license. And she went to Africa after she was 90 years old. And so, as Mary Alice Mo Henry, I've had a lot of fun working with different people in different aspects of healthcare. And so, thank you, gentlemen, ladies, and let's get it on.
All right. So we got one more colleague that has joined us, Dr. Pete. Dr. Pete, would you introduce yourself to our audience?
Hello to my esteemed colleagues. I'm happy to be here. Thank you, Congressman Davis, for continuing this forum to allow our community to get some good health information. I'm looking forward to a vibrant conversation tonight.
Thank you. Thank you so much. Last week we had a great discussion on prostate cancer. And, during the week I got talked to a few people who actually were tuned into the program. They had some questions and they said that, this is something that they think we should, maybe add a little bit on to, and not so much, it's more so in terms of helping our community to make certain that people really understand the importance of prostate cancer screening and help people to understand what it is that they need to do for themselves. I mean, because this starts with the individual patient, as most disease process is. I mean, most people tend to wait until their symptoms, but this is certainly a situation and a disease that you do not wait for symptoms. You need to have a plan in place, plan that's orchestrated by your primary care doctor, and in terms of how you're going to approach this disease and stay with it and make certain that so what I'm saying is all males have a prostate unless it's been removed, and therefore if you're a male, you need to make certain that you have these kinds of that you take this as a serious situation, because it is a problem that is on the rise, and actually there's been a prediction by a urology group that there's going to be a doubling of the incidence of prostate cancer in the next 15 to 20 years. And considering the fact that there's already about 1.4 million cases of prostate diagnosed each year, that's a lot of prostate cancer. And that and so so we need to make certain that that our community is aware of that, understand what are the risk factor, and understand what we should be looking to do as individuals. So do we have a urologist on with Dr. Mason? So Dr. Mason, why don't you kick us off in terms of talking about the approach in terms of what men should need to be doing?
Well, first of all, thank you very much, Dr. Miller. And I did have the honor to treat many men with prostate cancer and just regular prostate disease, and then prostate concerns without disease necessarily, for almost between 26 and 30 years of time. But before I get into the cancer part, understand the prostate is a gland that sits sort of right underneath the pubic bone, the pubic bone. That's the bone you right at the bottom of your near the bottom of the abdomen. You feel that bone right there, and underneath there is where the prostate, or there's where the prostate is located. The prostate is just one of the things necessary for reproduction. That's what one of its major functions is about reproduction. That is, that the prostate makes a lot of the fluid that comes out when a man has an orgasm. In fact, most of it that comes out when a man has an orgasm is from the prostate. It is not sperm. Sperm is the least of the volume. In other words, the least of the fluid that comes out, but the prostate makes the fluid that helps transmit the prostate and transmit this fluid. And during intercourse, those fluids, if are deposited into a vagina and of a woman who is childbearing age, can result in a pregnancy. That's a major thing for the prostate, and that's why we have it, and that's what we use it. What it's being used should be used for. There are other things. The prostate, like everything else, is subject to other diseases, and it, like every other organ, any other organ in the body, can be subject to cancerous changes. Usually, before the cancerous changes, it may enlarge, and these are things that are just enlarged. Prostates are not abnormal. Most prostates will enlarge. Some will enlarge quite a bit. Some won't. But the key is not the enlargement. That's the problem. Is when we start seeing these changes in the cells of the prostate that create a situation where it begins to produce a little more of the fluid we call PSA, and that also is the way that we measure. One of the things that we measure, looking for that, as not that if it's elevated you have prostate cancer, but it's something means that we need to take a closer look, and that's what you do with your urologist. And then there's ways that you can feel the prostate, and also we have machines that can actually measure the prostate. And if the PSA goes up to a certain level, you need to have that conversation with your primary care doctor and your urologist to determine whether or not you are appropriate candidate to have a piece or pieces of your prostate taken out by using a needle and looked at under the microscope to see if your enlargement of the prostate, or the elevation of your PSA, is related to just an enlarged prostate, or is there some other things that we should be concerned about? And maybe I'll just stop right there and take questions, or if there's other things that we need to clarify, I'd be happy to do that. But that's what prostate is. That's why it's there. That's what it does. And enlargement of the prostate is not a problem unless it begins to obstruct or slow down the flow of urine. Then that's another problem. Doesn't mean you have cancer. It just means that there's enough enlargement there where the channel where the urine has to come out is now sort of constricted or squished, so to speak. I think that is that good enough.
That's good. Yeah, I'm going to go to Dr. Pete and Dr. Pete to sort of talk about when should men begin to have screening for prostate cancer.
Hey, thanks, Dr. Miller. So there are large scientific bodies that meet and determine what's a good age group to test. I will see patients early in their 30s, and patients will say, I want to be tested for prostate cancer. And, it's difficult to tell them, or, you have to break the news that, you're not quite at the age of when you should be tested for prostate cancer. But I will say this. So those bodies of scientists, and what they do these studies to determine what is the age in which they're going to maximally benefit, or the patients will maximally benefit from being tested. And just so that you know, there's not just one large body of scientists, there are several. So you have the American College of Urologists, which is Dr. Mason's a part of, and then you have the American Cancer Society, you have the United States Preventive Task Force. So in general, as a primary care doc, we tend to look at the United States Preventive Task Force, and they recommend at the age of 40 for patients, for men to be tested for prostate cancer. That means a PSA. But now there was a few years ago that there was a study that came out that indicated that the PSA, which is the prostate specific antigen, that's the protein that Dr. Mason mentioned, 0 to 4 tends to be what's considered to be normal. Above 4 means something's going on with your prostate. Not necessarily that it's cancer, but something's going on, and that we need to look further into that. And that usually means, for me as a primary care doc, I'm going to refer those patients to a urologist to get a tissue sample of that prostate. But I will say this, that with that most recent study, it showed that the PSA was not a reliable test. Now, later it was found that there was several sort of flaws in that study, including sample size, including it did not have an adequate amount of African-American men in that study. So as of now, we're still doing PSAs as a way to screen for prostate cancer. It should be noted that even you can have prostate cancer even if that number is between 0 and 4. And then you should also note that you can have a prostate level of 7 or 8 and still not have cancer. So even though it's well beyond the 4 number. So what we do recommend in those cases is that we will, again, Dr. Mason can speak more about this, is, we can check you more frequently if you have an elevated, those 8s and 9s PSAs and your initial biopsy test is negative. We can send you back to the urologist 6 months later, do another biopsy. They can do what they call a saturation biopsy, where they take more tissue samples than what's considered to be, normal. So those are the things that we look at in terms of to determine. And like we've said here before, many patients will think of any kind of disease process in terms of symptoms, to say, well, if I don't have any abnormal urination pattern, if I'm not getting up at night, using the bathroom several times, if it's not difficult for me to urinate, then that means I don't have prostate cancer. Right. And that couldn't be further from the truth. So the reality is, if you're waiting for symptoms, you're going to shoot yourself in the foot. And so we should just note that 0 to 4 is normal. Beyond 4, that means there's something wrong with your prostate. But we should also note that you can have prostate cancer even though that number is between 0 and 4. You can have a 2, and that 2 could be prostate cancer. Now, how do we know? If that rate of the increase is what we look at. So let's say a couple of years you had 0.5, 0.4, you had a 0.3, a 0.6 again, but then it goes from 0.6 to 2. The rate of that increase indicates that something's going on with that prostate, and we shouldn't ignore it, even though that number is still between 0 and 4. I don't know if Dr. Maya or Terry, Doug, you guys want to chime in on that? I've been talking a lot.
Well, you're right, but I'll just say very quickly, the other thing that we didn't mention was the examination, the rectal examination. So you say, what is a rectal examination about it? Well, what we're looking at is that usual normal tissue feels more spongy. Feels like a tennis ball. I mean, not tennis ball, but one of those little rubber balls. And it feels like that. But if you are thinking, and we think of something that when it feels like your knuckle right here, when we put the finger in the rectum and we feel your prostate and it feels like your knuckle, then that's something that concerns us and will perhaps lead to taking some tissue from that particular area to see if there is cancer there, irregardless of what your PSA is. So, elevated PSA is certainly something we want to be concerned about. But a normal PSA, even with the nodule, is something urologists still are going to be concerned about. And your primary care doctor is the one that does your rectal most of the time. They can pick it up, or oftentimes they'll send you to a urologist if they have a question. And I just wanted to make that point, Pete.
Also, we one of the things we want to make certain of is that a lot of time people will go to the doctor and they got a normal PSA and it's one or less than one. Now they said I feel good, and you should, but we want to make certain that they don't just leave that there forever. That doesn't. So, Dr. Meyer, would you talk about that? That even though last year your PSA was normal, how often should a person get follow up in terms of their PSA?
Well, I've been starting at the age of 40. I got some feedback. I've been starting at the age of 40, and I've been doing it annually. I want to just also double down on what Dr. Mason said. A lot of times it's easier to do the PSA, which is a blood test. It's easier to convince somebody to get that PSA, right? For me in my practice, a PSA can take us far. It does not replace prostate specific antigen, is the blood lab. The blood lab does not replace a physical exam, right? It's like only getting your blood drawn for a whole bunch of stuff and never going to the doctor and letting them listen to your heart or listen to your lungs, look inside your ear, listen to your abdomen. It's the same thing. So that does not replace the digital rectal exam, or what we've been calling a DRE. Okay. So to introduce the subject for a lot of my patients, I do lead with the prostate specific antigen, especially if it's a person coming in and we're just having a conversation, or if we're starting virtually. But that's usually my lead in to say, at some point we're going to need to do a digital rectal exam. So at your next visit, or at the next year, be prepared for that, because nobody likes a surprise digital rectal exam, right? But it's so necessary. I did have a question, Dr. Mason, that I get a lot. Some of my patients don't want to screen for prostate cancer because they're like, okay, if you take my prostate out, how does that impact my ability to have an erection? How does that impact my ability to make sperm?
That's a great question. And obviously, if the entire prostate is removed, there is no more semen for ejaculation. Because remember, I said earlier, one of the major functions of the prostate is produce the semen, with the exception of the sperm. Now, the prostate doesn't make the sperm that comes from the testicles, and it all gets mixed when we have an orgasm. And as we mentioned before, that combination of the sperm and the seminal fluid or the prostatic fluid is all mixed when you have an orgasm. And all of that is what's necessary to create an environment that's helpful to the sperm, because the whole idea, even though we use having sex for a lot of different reasons, but the official reason for having sex is to make babies. That's the real purpose for it. I know we do a lot of things and we have a lot of different sex, but that's what it's really about. So you're right, Dr. Maya. There are a number of things, but we need to be sure that people understand that none of this stuff is 100%. Elevated PSA doesn't mean you have cancer, but it doesn't mean you don't. And when you do a digital rectal exam, the size of the prostate has nothing to do with whether or not you have prostate cancer or not. I've seen men with huge prostates, and then the PSA is actually sometimes normal. And I've seen men with very small prostates, which doesn't mean anything bad, but they could have cancer. So that's why it's important that we do What you hear here is this chorus between urology and the internal medicine and or family medicine doctors, all working together, because the family medicine doctor or internal medicine doctor will be the one to make the referral when appropriate to the urologist. And I'll stop there.
And you know what? I asked that question just like a person without a prostate. What I meant to ask was, if I have my prostate taken out, can I still have an orgasm?
Yes, you still feel it, but the most of the fluid that comes out that you would have had before when you had a prostate won't be there.
Still feel it. That's what I meant to ask. Yep.
You still
Okay.
get the feeling like you have an orgasm, but you're shooting blanks.
I think that's an important thing because obviously, um, as Dr. Mason mentioned, that having orgasm, having sex is very important in most men's lives, and oftentimes when there's something that threatens to take that away, they become very hesitant about moving forward. And I just and adding to that though, if you do get prostate cancer that go on to destroy your prostate gland, not only are you going to not have sex, you're going to be sick, and you're going to ultimately probably have a shorter lifespan. So all these things have to be taken into consideration. But again, it's important for you to understand that you can still have sex. I mean, even and Dr. Mason, at some point we'd like to, in this conversation, have a talk. Because again, some men will have a problem with having an erection after having prostate surgery. Just to let men know what are the alternatives, so that is not something that's eliminated. I think that's an important thing, to get rid of some of this hesitancy that men have, because that sex is very important and very precious to them, and anything that threatens to interrupt that becomes a problem.
Let me just interject here. There's another dichotomy, another sort of categorization. A lot of times the prostate doesn't have to be cancerous in order for it to create problems with urination. And just we have problems with urination, that is getting up at night to go to the bathroom. You got, the stream isn't as strong as it used to be. You don't empty your bladder like you used to empty your bladder. Those aren't necessarily things related to prostate cancer. Those are things that are related perhaps to just enlargement of the prostate. And you still need to get a PSA, and you may need to be referred to a urologist, particularly if you're not emptying your bladder completely. So this team approach of the primary care doctor and urologist, that's the way it ought to work, because there is a handoff to the urologist from the primary care doctor at a certain point. Now, obviously, if the prostate is totally removed, then even if you have an erection, you will still have what you feel as an orgasm, but there'll be no fluid coming out. If the prostate is totally removed, that's just the way it is, because most of that fluid came from the prostate. Now, can you still have an erection? Yes. Is it always going to be the same as it was before? No. There are many men who are having problems with erections who don't have any issue with the prostate. And I'm sure my internal medicine colleagues and family practice colleagues can comment on that, because I'm sure they see that with regularity.
Dr. Graham, you want to jump in and add something to this conversation in terms of these issues?
So I was just curious about the idea of radiation therapy, about putting seeds in the prostate. And the other thing that I was really curious about is, if you decide to decline treatment, you decline surgery, what does the future look like?
Well, if you're asking me that question, I think that's a conversation you have with at least two people, your urologist, and perhaps, if depending on where you are, if there's an oncologist, a urologic oncologist that is a cancer specialist, that'd be someone you could have a conversation with as well. But prostate cancer in and of itself is not a death sentence. Usually treated early, you can live quite some time if it is cancerous. Now, if you're having the prostate operated on because it's enlarged and you're noticing You're getting up at night to urinate more frequently. When you do go, you don't feel like you empty your bladder. The stream is much weaker than it used to be. And we do a test to determine whether or not when you do urinate, all the urine came out. And operating on the prostate for non-cancerous problems can create other issues, but it has usually less side effects from erections and things of that nature. So it's important to understand that treatment for prostate cancer is one thing, enlargement of prostate is another treatment that is different than the treatment that you do for prostate cancer.
Let me ask if we know. I noticed, Dr. Miller, you indicated that there's likely to be an increase in prostate issues. And I thought about it. I've got 3 friends who right now, all 3 of them have issues and they're all undergoing treatment. One is expressing some behavior concerns, actually talking about dying. And I mean, that's is that something to be expected?
Well, if prostate cancer is detected early, then one could have a pretty normal amount of pretty long time to live on. Now, the issue that I raised in terms of the increase in the number of prostate cancer that is going to be diagnosed. Now, some of that is something that resulted from something good, and that is that prostate cancer occur most commonly in older men. And so because men are living longer, there are more men, there's a more likelihood that we're going to have more men with prostate cancer because men are living longer. And so it's not necessarily related to anything that men are doing other than the things that are making them healthy and having prolonging their life, not anything negative to explain that. One of the other issues that I really want to I was going to ask Dr. Pete, and I wanted Dr. Meyer and Dr. Mason. What is the youngest age that you've diagnosed any patient with that had prostate cancer?
42.
42. Okay.
42, and then I'm sorry. Go ahead.
No, go ahead. No, I was going to say, go ahead. You go ahead with that.
42, and some of the things that were associated with that. It was an African American male with a family history. Father had prostate cancer, was a smoker, and heavy grilled meat eater. I've never seen here's what I don't know what you can disclose. I've never seen the grilled meat associated in literature with prostate cancer, but I do see it, grilled red meat associated with prostate cancer in my patients. So that's not literature. That's not literature. The things that are literature are smoking, a diet low in fruits and vegetables, family history, those type of things. But I can tell you, I've seen a lot of grilled red meat, grilled pork, things like that coming up more in my patients. And then African American or a minoritized underserved community origin. That's literature. What I did want to say is depression is, and I'll check. I'm pretty sure it's 1 in 6 men who have experienced prostate cancer, and I think the average amongst just men in general tends to be about 1 in 18 or somewhere between 1 in 18 and 1 in 20. I'll go ahead and check those numbers just to make sure I'm communicating the exact numbers as we go. But 1 in 6 versus 1 in 18, 1 in 20, that is a significant that's a significant process, you know. But you know, one of the things that a lot of my patients that experience prostate cancer vocalize is they didn't know that they could feel their orgasms again, you know, or feel their orgasms, period. So thank you, Dr. Mason, for clarifying that, because for a lot of people that either exacerbated or contributed to kind of depression. And it was real, you know, and it did help to them to kind of know that and know that literature and know that fact that they could still experience orgasms, things like that. One of them even was like, oh, so you know, the likelihood that I, you know, if I did not want to have a child, the likelihood that I would have a child is lower. So they actually found some joy in that. So it's all kind of information all around for it. I'll send it to the next colleague as I verify those depression numbers.
What about you, Dr. Mason, the youngest prostate cancer?
I'm sorry, you asking me the youngest
Yeah,
person?
the youngest person that you've diagnosed with prostate cancer.
30s.
30s. Yeah.
In the 30s, mid 30s, I think it was. It's a long time ago. But you know, the diseases don't read the textbooks.
Absolutely.
And so, you know, they will do what they do. And Dr. Maya did bring up some dietary things that are important. Obviously, the better we eat and the more fruits and vegetables we get in our I don't want to call it diet. I'm now using Prince Asiel's term. The more livid we eat, and that is things that are helping us to stay here longer, will certainly decrease the rates of may decrease the rates of prostate cancer, and that's what you want. I think that you need to know, and I want to underscore what Dr. Maya said earlier. There's no feelings you get. There's no symptoms you get. And if you have a symptom that is directly referable to prostate cancer, it usually means that it is not a benign prostate issue. It is probably a cancerous issue, because the cancers of the prostate most of the time will go to the bones. And that's where you'll end up with your problems with the bones. We haven't talked about what we do with advanced prostate cancer, because there are some things that can be done and that are being done today to help people with prostate cancer live longer lives. And that's very important too. And maybe we'll get to talk to that. But certainly, if you do end up with prostate cancer, you will have a conversation like that with your urologist and probably with a cancer specialist called an oncologist, depending on what institution you're in.
I'd like to stick right here. Sorry. Journal of Urologic Oncology says 1 in 6 for men who have prostate cancer. CDC says 1 in 18.5. So a male with prostate cancer is 3 times more likely to experience depression, is what those numbers roughly say. Okay.
Dr. Graham, when you and I started practicing medicine, I don't think the PSA was around. So we you know, our means of screening was really the digital exam. And, you know, I know it was always a little bit of a chore, you know, being in primary care and having to convince some men that this was a needed and necessary tool. You know, and it still is. It's not that it went away just because the fact that we were doing PSA, as you know, Dr. Mason mentioned, that you can have prostate cancer even though your PSA is normal. So having a digital rectal examination of your prostate is also still valuable in terms of detecting prostate cancer. Dr. Pete, you had something? What's the youngest age you've diagnosed for prostate cancer?
Yeah, I gotta say young 40s. So maybe 44, maybe even 40. And I think the distinguishing picture here was there was a hereditary component. Like the person had several first degree family members who had prostate cancer. And I do think it's probably noteworthy to mention that in terms of all types of cancer, that yes, there's two major influences. Is one is environment, and two is genetics. I think people overestimate the amount that hereditary or genetics play a role in your development of cancer, and that your environment, because even though you could have a family history of prostate cancer, but if you do what some of the things that Dr. Mason and Dr. Green was saying, which is having a diet that's high in fiber, low in fat, exercise, a lot of key nutrients like vitamin D is key, and lycopenes that's in tomatoes are all key things in terms of preventing prostate cancer. And some of the things I try to tell my patients is that they come in for this test, right? And they figure, yes, I got a 0.2. And then they think that that's their protection, right? I got a 0.2, and now I'm off out of the office to do whatever, and not exercise and not eat my fruit and vegetables, and I'm like, hey, that 0.2 can turn into something different real fast, like the next time we do this test. So definitely I encourage screenings, but also you gotta put some skin in the game. You gotta put some lifestyle into this, and that means saying no to some things, and things that maybe from a historical, familial perspective we embrace, right? So we embrace, the fat and the meats and the juices and the gravies, but sometimes those things, and a lot of times those things are not conducive to living a long, healthy life, and that's cardioprotective and cancer protective. So, but definitely, we want to tell patients to have a lifestyle that's consistent with not having cancer. Is just as important as coming into the office to get those screenings done every year.
Dr. Pete, I'd like to chime in
Go
on
ahead,
what you just said, and that's not just protective for the prostate. You see, people worry so much about the prostate, but what's going to kill you first? A heart attack. So you shouldn't, it's one thing to have some vigilance around your prostate exam, and I'm not demeaning that at all. But we still need to understand that heart disease is still the number one killer of men, way ahead of prostate cancer. So we want you to understand, to what Dr. Pete just said and what my other colleagues are saying, that we do need to maintain those protective behaviors, which is what Dr. Pete mentioned in terms of, the fruits and vegetables with colors, and certainly watching your barbecued or meat cooked under very high fires and things of that nature. So we need to be just aware of that, because these are all things that work together.
Yeah, that's such an important part. I mean, we've been talking about early detection, but better than early protection is prevention. So it's if you need to do things that you can to keep from having the problem, and even though you're being screened, it's good that the screening is negative, because you've done something proactive and in advance that would prevent you from getting prostate cancer. So that's and as they say, an ounce of prevention is worth a pound of cure. So that is such an important thing, that we do whatever we can to prevent these diseases from occurring in our bodies.
I'd just like to follow quickly on that too, is that, remember, your rectal exam is a point in time. It's a point in time. Just because you got a negative exam and your PSA is okay now, doesn't mean it's going to be that way 6 months or 8 months later. So just as your blood pressure, and my internal medicine colleagues can comment there, but your heart health, the things that you're doing to prevent heart stroke and all these other things, these all things work together. These aren't separate. These are all things that are important. And don't forget, we're not talking about that tonight, but colon cancer. And because many of these things are also helpful in those areas. So, and I'm gonna stop there and let my um, ask my colleagues in internal medicine and others to comment on that, because we get so tunnel visioned with these diseases sometimes that you got to say, God, you got to understand this is what your whole life is about. You got other things to be concerned about.
Yeah, that's true. I mean, yes, people get attached to the problem of the month, so to speak, and focus so intensely on that. And when if they're focusing on their blood pressure, their diabetes, they forget about all the other things that they are doing, or things that they're not doing, to have a healthy body, and and have to have health that and prevention of diseases. So that is so important to really focus on those things, and not just the whole body is it's important, and not just the physical body, the mental body, the spiritual body. We need to focus on it all, because all these things can hurt and kill us and make us very sick. So we need to focus on all these things as we travel along this life journey.
Yeah, I just want to say, I think that's why it's important that you have a primary care provider and physician that you can go and see, and it's not a one and done, but you have several visits throughout the year, and we can decide as a team that we're going to focus on our screenings or health maintenance this visit. The next visit, we're going to go over blood work. The next visit, we're going to look at. So there's a multitude of things that needs to be done from your health perspective. And sometimes things come up and you didn't expect it, like random things that come up on your labs. And so you just want to make sure that it's not a one and done. You can come in and get things done in increments, because as you know, the system is not designed so that you're going to do everything on one visit. And so you got to have patience. You got to have a relationship with a primary care provider, and you're going to come in periodically to get things looked at and get these screenings done, and follow up with them and communicate with the healthcare team. So those things are important.
Yeah, and back to what Dr. Peters was pointing out is so important, and one of the other issues that's important is that whatever happened today is not static. It doesn't mean that whatever your situation is, you was in the doctor's office, and the doctor says this is what your blood pressure, your diet, your sugar is, this is what your prostate or your PSA is. That doesn't mean that things won't change. And because things do change, that means you're going to have a continue. You have to have a plan. This is not, you can't just, this life is so important that if you plan your finances or you plan anything else in life, you plan your vacation, you certainly ought to plan your health, because that is, one of the most valuable assets that you're going to have. So we want to make certain that people really focus on that, planning your health and working with the plan. Yeah, your primary care doctor is your team leader and your guide, and so make certain that you have someone that you feel confident in, that you feel comfortable with, but work with them. And if you don't understand something, make certain that you ask the question so that it can be explained to you. And I think that if the better you understand it, hopefully the better you'll be able to work with it and to cooperate with the process of receiving the health care that you needed. That is, a lot of time I've had patients to come, and then they had a PSA of this, and next year they come back and it's different, and they want, but I just had one last year that was, that's a year ago, and so things change over that period of time. So don't be surprised by those things, and don't get upset, but just be that if you're doing the things that you need to do, then continue to do those things regardless of what the results are. Dr. Mason, you mentioned in terms of people that do have advanced prostate cancer, what kind of things that can be done to help these individuals? I mean, sometimes people, didn't get started with getting their prostate evaluated, and so by the time that they do go, they go for something else. They find out that they have advanced disease. What is the alternative? What kind of things are available for those kinds of individuals?
I'm sure there's some newer agents since I was in practice, but I can tell you that the major mainstay of those treatments for men who have um, prostate cancer now that is widely in the prostate and it's perhaps spread to other parts of the body, particularly the prostate cancer spreads to the bones. And so what we used to use were agents that went just more than to the prostate. And these are things that sort of try to slow down the progression of prostate cancer by doing one particular thing, and that is slowing down or shutting off the male hormone testosterone. And that doesn't come without side effects, and the side effects can be important. And the major side effect, if you shut off the hormones, whether you shut them off in men or women, for that point of view, there's going to be a reaction. And in men, when you shut them off, men will begin to get hot flashes, just like women got when they went to menopause. Men will get and these hot flashes will last as long as the medication that you're taking for your prostate cancer. And I'm not saying this is the first drug you take. This drug is something that usually is a conversation between your urologist, your primary care doctor, and a cancer specialist. That's the people that's part of that team. And so having this medication to sort of shut off your testosterone then creates those side effects that I just mentioned. Hot flashes and I mean night sweats, all kinds of things. And so you need to be clear, and that's why it's so important that we do everything we can to try as be as healthy as we can, because as that's your best defense. Your best defense is being as healthy as you possibly can be, because that's what's going to help ward off the things that you're going to get. You're not a helpless victim. You're not going to get prostate cancer just because, many men will get it, but every man doesn't. And so you do the things you need to keep your heart in good shape. And the same thing that keeps your heart in good shape will help keep your prostate in good shape, will help keep your colon in good shape, will help do a number of things. And I would just defer to my internal medicine colleagues who have to do this on a daily basis to comment in that regard.
Dr. Peter, Dr. Meyer, you want to comment on the treatment for advanced prostate cancer, adverse effects?
I don't really have a comment on treatment for advanced prostate cancer's adverse effects, other than what we know about radiation and chemo. But I don't have any detailed. I usually with the I call them urologist, oncologist. So I usually kind of just take their lead. But I've never for myself prescribed a 1 and 2 treatment. On the other end, the only thing I've done as I can't say only, something that I'm proud I've done to serve patients as a primary care is help them with supportive measures, during that part. If it's nausea, then we help with that. If it's pain, we collaborate with pain management or oncology to help with that, and just keep people comfortable in that advanced stage. And so that's usually my role as primary care.
Yeah,
very important one. Mm-hmm.
Yeah, same here. I think my colleagues did a great job of outlining kind of the course that patients will have when they have metastatic or advanced prostate cancer. Typically, those treatment options, the thing about chemo is going to kill good cells along with the cancer cells. So patients tend to be very sick, and typically can go in the hospital sometimes, not just because of the treatment for the chemo, but also what the chemo is doing to the patient. So they might develop a systemic infection. So it's a real rocky road, and we have to watch these patients very carefully. Minor things could be major things, like a urinary tract infection that we could treat as an outpatient with some oral antibiotics. You can develop something called urosepsis, just because the chemo has wiped out the entire bone marrow, and a lot of the patients don't have a defense mechanism to fight regular infections. And so it does mean when you have advanced cancer, and we have to use stronger systemic medications like chemo and radiation, it does mean a rockier course.
All right.
I like
All
to
right.
just add to what Dr. Pete is saying, and just so the listeners, people that are listening out there, it's not all this happens at one time. None of this happens all at one time, and there's a stepwise way that things are done, and so you don't get all these things at the same time. If you start out with elevated PSA, you'll have options. If you're First of all, the first thing we do with any kind of cancer, prostate or anything else, is try to figure out, has that cancer moved away from the organ it started in? So if it's still in the organ that it started in, we can apply what we call local therapy. In other words, we can just work on the organ. So maybe in that case, if the prostate cancer is still only in the prostate as best as we can identify, and the way we do that is we may take additional biopsies to determine whether or not we see how much of the prostate is involved in the prostate cancer. It may only be a small amount. That then gives you some sort of treatment options that are a little different. Once the prostate cancer is beginning to move beyond the prostate, then certain treatment options aren't as available anymore, because those are just treatment options for the prostate cancer being in one spot. And that's usually surgery, that is taking out the prostate, or radiation. And then sometimes there may be a combination of the two. And that's something you have to discuss with your urologic oncologist and your primary care doctor. What we talked about later in terms of some of these other things that give you hot flashes and things of that nature, those are the modalities that come later down the road. And so like I said, you don't get all this at one time, but your doctors will take you through the steps that you need to take as you're going along. And because we also understand that there are side effects with these medications that you need to know. And so some of these side effects, particularly those medications that shut down the testosterone, which is the male hormone, can create problems with, just like a woman, you would end up with hot flashes. You'd end up with a number of other things. So these aren't things that are to be feared. They're just to be understood. And your oncologist or your doctors that are treating you, and they're usually going to be a team of doctors. And sometimes you may start out with just a local treatment with a surgery or radiation. And depending on what's happening, you may have to progress down that course of other therapy. So I just wanted to put it in. It's not, you don't get it all at one time, but it is staged in a way that's consistent with treating your disease its best.
All right, thank you. I think this is, has been the purpose of this conversation is, again, help to inform our community of what's there, what they can do, and what they should do in terms of trying to prevent these problems from occurring as best as they can. Sometimes the best we do still fail, but there's an old saying that nothing beat a failure but a try. So you got to try to do what you can, because if you don't, and you're certainly putting yourself at greater risk of having things to come on and to cause you a bigger problem, as Dr. Mason had talked about, how these processes don't just start and then suddenly you're just inundated by it, but they start and they progress. So that's so important. So it's important that our community understand that, not have this fear, but move forward and take care of themselves. See, Nikki is back here, and so Nikki, I think you probably want us to sign off.
So yeah, this has been a wonderful conversation, and I know you guys have did our until next Mondays, right?
No,
No, until next Mondays.
well,
All right, Doug.
we
You're
haven't
until
done next time,
Mondays?
but yeah. So Dr. Maya had to drop off, but she did leave until next Monday. She says, treat your insides like you do your outside. Give yourself the Lexus, the Porsche treatment. Prevention is the best treatment. That's the Porsche. All right. So, Dr. Graham, go ahead and give us your until next Monday.
Well, I kind of wanted to add to that because I've been thinking about this discussion. Everyone's talking about annual checkups and having this checked and that checked. Kind of reminded me when I had my car and I was commuting an hour a day in both directions. You have to get your car checked on a regular basis. If you don't get your oil changed, you don't get your oil filter changed, you don't get your brakes checked, you have problems. So the whole concept behind these regular checkups is early detection, so you can have better brakes if the brake lining is wearing down. You got a bald spot in the tire, get the tire fixed so you don't get in the accident. So I really like that philosophy of the car analogy. I just want to give a shout out to the people who did the study, who recommended the monitoring. I'm not sure that everyone understands this took thousands of man hours to study this and to come up with these recommendations. So this isn't just something that's rabbit pulled out of a hat. This is well studied and well researched to the best of our knowledge as of today. So think about your car, get your car serviced regularly, get your health serviced regularly.
Right. All right. Dr. Pete, till next Monday.
Yep. I just got to echo what Dr. Graham and Dr. Mason said, which is, don't treat your body like all these separate organs, like they're not connected. So there are some common things that you can do that will help all your organs function better and will delay the progression of disease, whether it's blocked arteries or whether it's abnormal cells that might turn into cancer. So if you get regular exercise, you eat lots of fruit and vegetables, you keep your mind in a very positive state, your spirit, you laugh, you go to church or synagogue, wherever you decide to go, if you're treating your body holistically and that will delay the progression of disease in your body. And most important, where does disease come from? Inflammation. So keep getting your body into a state of maximum relaxation, along with taking in nutrients like vitamin D and selenium and B complex and berries and all those rest of those things. Eat those things and be happy and laugh. You'd be surprised, and go see your doctors so we can do those tests and just make sure that your PSA levels are down, your colonoscopy is fine, pap smears, mammograms, all those things are important as well.
Exactly. Dr. Mason, until next Monday.
I like to use the car analogy. Most people take better care of their cars than they do their bodies. They tend to know when it's time for the oil change. They tend to know when it's time to get the brakes checked. They tend to know different things that have to happen. They're very cognizant of, especially if they're buying one of these really nice cars, of the kind of gas you got to put in order for the engine to function normally, as well as the lubrication, oil changes, and things of that nature. So we need to take that same sort of philosophy when it comes to our body. We should, if you got one of those cars that are very high performance, then you got to put different kind of gas in there than you put in the regular other kind of car. And the body, nothing performs better than your human body. So you should be putting the best possible food you can put in your body, and know that when you don't, you're cheating yourself and your body. So know that you don't, you can't wait for a symptom. Symptoms are the absolute worst way to think about a disease, because there is no symptom for most diseases in their earliest most curable stage.
Amen to that, brother. Amen. Yeah, for my until next Monday, I'm just simply going to say, hey, an ounce of prevention is worth a pound of cure, and you're worth cure. You're worth the cure. So invest in keeping yourself healthy so that you don't have these problems. Nobody wants to be sick, but you gotta invest. If you don't, then certainly the disease is going to. It's just like I do gardening, and if I don't get out there and cut the grass and the weed, they're gonna grow up, and they'll actually overtake everything. So it's important that we invest in our bodies. Nikki.
Well,
Nikki?
Congressman, take us home.
Well, until next Monday, if we do 1/10 of the things that we've been told, I got a feeling that we'll be here a long time. The information has been so profound, and it all simply comes together. If you practice good health, you're probably going to experience a state of healthfulness that will keep you not only well, but will also keep you here for a pretty good while. So, ladies and gentlemen, thank you for a wonderful discussion. We will be observing uh, Sickle Cell Awareness Month. We have a resolution that we will introduce tomorrow that Caleb has been working on. So have a good night and a better tomorrow. Thank you, and so long.